Committee today, Monday, the 22nd of June. I'd like to extend a welcome back to this committee to Councillor David Cox, and to say thank you very much to Councillor Rosie Dawson, who's no longer on this committee, to thank her for her contribution while she was on this committee. I'd also like to welcome Peter Hay, our Specialist Advisor. This meeting is being live streamed, so please use the microphone and have them pointing at you when speaking. We have some apologies today.
Thank you. So we've got apologies from councillors Tildesley, Ketchin and McGough, and then we've got councillors Hodson and Gent remotely.
Thank you. And I understand that it's not a formal apology, but Sove Wright cannot attend today. So Nicola Tribble, Senior Commissioning and Market Development Manager, is attending in her place. Welcome, Nicola. So now if we could go please to declarations of interest. Members, please declare any interest you may have in any item to be considered at this meeting prior to any discussion taking place on that item, either now or at the beginning of the item. So members, does anybody have any declarations? Hi, Councillor Sue Davis.
Yeah, sorry. Yeah, I work alongside SWAST.
Thank you. So now we're moving on to item 4, which is the minutes. The minutes of the meeting held on the 23rd of March 2026 for signing as a correct record. Is everybody happy for me to sign them? Thank you. Items requiring urgent attention. There are none. Item 6, public participation. There are none. So moving on now, please, to matters for consideration or review. Item 7, client financial services update. And also we have a report from the Director of Finance and Public Value. And today we have with us Councillor Richard Keeling, the portfolio holder, Lisa Evans, Head of Adults Finance, Samantha Clapp, Head of Client Financial Services, Councillor James Bukowski, Cabinet Member for Finance and Public Value, Matt Thorpe, Director of Finance and Public Value, Tanja Foster, Director of Adult Social Care, Nicola Tribble, who I've already introduced, Sarah Macarath, Head of Quality Performance and Redesign, and Kevin Beveridge, Head of Integrated Adult Social Care Operations. So if I could hand over first of all to Councillor Keeling.
Thank you very much, Madam Chair, and I'll be to the point. It's going to be quite a long and hot meeting. This report outlines how adult social care charges are assessed and highlights improvements in financial assessment performance since 2025. Waiting times and backlogs have reduced significantly with faster assessment completion and better service delivery. At the same time, increased billing has led to higher recorded debt, prompting a revised strategy focused on prevention and recovery. Ongoing improvement work includes increasing staff, improving process, strengthening communications, and using better data and oversight. Further actions are planned to sustain progress, reduce waiting times further, and enhance customer experience. Overall performance is improving, but continues to work. Continued to work is needed to meet targets and manage demand and debt effectively. Madam Chair, I and the team are here to answer any questions you and your committee have.
Thank you. Do any of the officers wish to add anything?
Only to add that improvement in timeliness is a core priority for adult social care, and I think there's been a huge amount of work undertaken by Client Financial Services, and it's a positive report, but as Councillor Keeling says, we've got further to go. And I know you announced quite a few of our team we're here, but I think it would be Lisa Evans, and I can't see Sam So Lisa Evans probably to field most of the technical questions I would suggest on this paper, but we will be happy to respond on other elements. So if we can hand over to Lisa if there's any questions.
Thank you. Committee, questions for the officers on this report? Councillor Rogers.
Thank you, Chair. There's an organisation called Compass Health expending what must be millions of pounds, raising expectation to residents nationally to challenge their health and social care costs on a no-win, no-fee situation. Have we had any information affecting Devon on that status of Compass Health?
No, we haven't had anything through. We don't seem to be seeing an increase on the back of that particularly. We are seeing an increase in challenges, but not necessarily linked to that company.
Thank you. I'll ask a question if I may, please. So obviously that's really fantastic that the waiting list, the numbers waiting have for assessment have gone down from 3,144 to 1,098. That's a huge reduction. So that's excellent. I've just wanted to know, please, how you reached the target of 750. So it says in paragraph 4.4.2, the service is working towards a steady state position of approximately 750 people.
So that's based around benchmarking and where we think we should be sitting well with other authorities and what best practice looks like in terms of making sure that we are adhering to the Care Act as well. So that is largely around benchmarking.
Thank you. And just following on from that, in paragraph 4.4.5, there's reference to aged debt standing at 65.8 million. So I did ask the Cabinet Member for Finance if I could have a breakdown of what that comprises, because it's obviously a really large figure. And it's not clear to me the extent to which that's recoverable, the extent to which large bills have been sent out to people. So I wondered if you could talk around that figure, please.
So we have started to pull together something for you, and I think that was hence the conversation we've had around having a masterclass where we could go into that in a bit more detail. Around 25 million of that is under a year old, and the rest of that is older than a year old. We have about 6.5 million that is currently secured, and we have another 1.3 million where the debt is secured by other means or is in the process of working towards securing that debt. We're constantly looking at ways to try and make sure that we are securing debt in an appropriate way, and we are targeting our recovery work on core groups within our adult social care client charging area to make sure that we are appropriately working with people and their representatives to make sure we are recovering as quickly and consistently as we can.
Thank you. Before I ask any other questions, members, thank you. Councillor Julian.
Yes, thank you, Chair. On 4.6, they're talking about, caring. I mean, people that go to college or whatever, universities, and then they come into the care and they're thrown in the deep end. I think it'd be better if they could, rather than throw somebody in the deep end, is they work alongside other carers so they can understand how it works, so they can get used to how it all happens, because that's the only way we're going to be able to make this more efficient and more streamlined if people are not just thrown in the deep end and they do university or whatever, but work alongside of people that are doing it so they feel more comfortable rather than shock. And then they say, oh, I can't do this, and walk off. I wonder if you could, somebody could explain that to me, please. Thank you.
Sandra.
Yeah, I think the question relates to our transition from children's service into adulthood. I would say that we've undertaken a transformation programme of that particular area of the service over the last 2 years, and we are seeing much better engagement with parents and families and young people through that process as a result. And we are, as you say, able to sort of support people through a variety of different ways, including peer support, to reduce the impact of that shock of the transition that you've outlined. So it is an ongoing piece of work, and we are seeking to make improvements in that area.
Thank you. I'll go to Councillor Nick Hookway, please.
Thank you, Chair. So I agree with you and your comments at section 4.43 that the number of people awaiting assessment coming down from over 3,000 to just over 1,000 is a very positive piece of progress. However, seeing as I'm a person who's relatively new to this type of issue, I would like to know how the assessment takes place, what methods are used to take the assessment. Is it paper-based? Is it IT-based? Is it phone-based? Is it face-to-face, and so on? And also, what happens to those residents who are on their own and simply cannot complete an assessment? Thank you, Chair.
Thank you, Lisa.
Yeah, so we look at the accessibility requirements of all of our clients when we're working with them to do a client financial assessment. A lot of this will be done over the telephone. If there is a necessity to meet in person with a client, that can be arranged. We do as much as we can on paper to give to people time to think about things, and then we talk them through everything. This also links with what we can do online. There are various methods of completing a financial assessment. One of the things we are we're considering as part of our new computer system in the future is an online financial assessment tool as well, where people can start that first stage to see what it might look like for them. And again, they can be supported in that space. But what we do try to ensure is that if there is accessibility issues or people are struggling, that they've got an appropriate representative to work with them to help with that understanding and to help with that process. But we do work very closely with people to make sure that they're not sort of disadvantaged.
Chair, thank you for the answer. Officer, may I just ask a very quick supplementary question? So when you talked about the new online tool, are you referring to the JAX system?
Yes, I am. It would be part of that system in the longer run.
Peter, would you like to? No? Thank you. I think one of the things that I've picked up is actually going on to the complaints report, which talks about issues around financial concerns. And one of the things that report picks up on page 22 is that financial concerns, whilst not always the most common, had a disproportionate emotional impact when information was unclear, late, or could not be evidenced as having been properly explained. And I would like to ask Lisa how, I mean, there's been huge progress in terms of the reduction in delays in financially assessing clients, but can you tell me, please, how you've tried to ensure that that you have done everything you can to reduce emotional impact and to ensure that large bills aren't being sent out, large and unexpected bills?
Communication, since I came into managing the team, is one of the things I'm very keen to improve. We're taking learning from all complaints that do come through, any feedback we get from whatever forum, and we also work very closely with the service to make sure that we're communicating effectively with all of the adults that we work with in terms of client charging. We're trying to improve in terms of training. We're looking at our processes and how we align our processes and make sure that our comms are a very key consideration throughout all of that. In terms of the larger bills, if there is a larger bill that needs to be raised, and that would be fully communicated with all of our clients, both in terms of the amount due, ensuring that they are in a position to pay it within a timely way. And if they're not able to, then we look at how we can arrange that. And that we'll also give them an indication of when that would come out in terms of an agreed date. So there's the communication, it has been noted, could be improved in some areas, and we are starting to see real improvement there. So as I say, we're taking all feedback we get and we're learning from that and making sure that we improve our training, improve our sort of when we're recruiting staff. Yeah, I think that's covered it.
Thank you. I mean, I do note that there are 70 complaints. I mean, I know there's a lot of cases, and you've really improved the waiting times, but there are quite, on page 20, there's 70 complaints. So
I would expect to see a slight uptake in complaints because of the sheer volume of clients that we're getting through, whether that be from a financial assessment perspective or in terms of the collection of debt, because we're being much more rigorous in that space now. So that is going to increase some activity. Those numbers aren't acceptable, and that is something we are working towards to try and sort of bring that down. But yes, the numbers are higher at the moment, but we are looking and working and looking all the time at how we can bring that down further.
thank you, Tandra.
I was going to make the same point. I suppose the report overall, we got more people being positive about the services that are delivered by the council, and that doesn't diminish the complaints that we do receive. We absolutely have to investigate them. We have to learn from them in the way that Lisa's just outlined. We are on an improvement journey though, and we do want to get to that 750, and the likelihood is there will be people having realising the amount that they have to pay towards the cost of their care, and it's always a sensitive conversation. I suppose the other point I wanted to make is that obviously client financial services have that direct contact, do the financial assessment, but from the first contact, very often we're trying to talk to people about the fact that care is not free at the point of delivery in the same way that the NHS is. So it's a tricky conversation. People don't always retain the fact that they've had that. So you might have had that conversation more than once, but once that bill lands, I think it is quite it's a difficult one for people to manage. But that's why we're trying to do the improvement to reduce that down as far as possible.
Thank you. And I would really recognise that actually it's a really difficult, a really challenging role trying to, recover financial or finances and bill in these circumstances. So I really do recognise that. So I don't know whether sorry, Councillor Rogers.
Thank you, Chair. You know, the 65.8 million in 4.4.5, how much of that debt is where residents have sadly died or gone into other forms of support care? So do we have that data?
Apologies, around a third of that debt is around deceased estates. So that will be clients who have deceased.
And what's our recovery plan? Because obviously that's with the estate. Is there issues that we can't seek recovery through the estate?
That's quite a complex area, and it can be very time orientated. So very often it's around we have issues with trying to identify an appropriate representative to manage the estate for the clients. Once we've got that into place, there's often very complex negotiations and legal processes around securing that debt and then recovering where possible.
So it's obviously a key part of adult social care. I think a masterclass would be really helpful because the way that you work with people who are in residential care is different to people living in their own home, the arrangements that you might put into place, how you work through that, and then getting into that point about holding on to debt. It's not unusual for local authorities to hold a significant amount of debt where somebody's gone into a care home and their partner is still living in their family home. You would have to wait for that home to become available for the debt to be settled. And I think I think it would be really helpful to have a longer period of time with some more people from the client financial services to talk us through what we do, and then we can also explore as part of that. So what do we do when it gets a bit tricky with getting the money back in, because clearly it's part of how the council balances its books. If we put the money out, we do need to get the money back in to balance it. But I think that would be better done in a masterclass.
Thank you. I would agree. I think, I really welcome the reduction I mean, that is a really significant reduction. That is really good that the waiting lists have come down, but for financial assessments. But I am really concerned about the age of debt because, yes, I understand that there's challenges, but it's a very significant amount of money that actually could potentially, some or all of it, be being used for people's care, and also the fact that a lot of it sounds like it's not secured. So from what Lisa said, it sounds like 6.5 million is, and then there's another 1.3 million, which leaves an awful lot of unsecured debt. So I do think that that is a concern, that figure, and also we don't have any figures on, has that figure increased dramatically as the waiting list has gone down. I understand that a lot of that is less than a year old, but I think there are questions about that level of debt and whether we're going to get it back as a council. So I do think that we do need to do further work as a committee around that amount of money and around understanding. And also I am concerned about residents and their families receiving really large and unexpected bills. And that's a point, sorry, that financial assessments has come up in some of the ombudsman findings as well. So I kind of think that there's a lot to be welcomed, but also there's more to understand and to challenge around the debt and the way that the communication. So I don't know how the committee would feel about welcoming the reduction in financial assessments, but expressing concern about the level of age of debt and seeking to do further work through a masterclass. Councillor Julian.
Yes, I think absolutely, Chair. I think we need more transparency on there so we can understand where the money's going, what they've done to claw some of the money back. I think because we just talk about it and nothing, and then we're just a talking shop. I think we need to have more further depth scrutinise what's going on with the debt. And I think, and I agree with you, Chair, I think we need more investigation. Thank you.
Thank you. Councillor Rogers.
Do we have a breakdown of that debt by financial year, and how far do we go back with that debt?
We do. We can make that available. I haven't got that to hand with me at this moment, but that is information we can make that available as part of the masterclass.
Do any members have any comment? Do we agree that that we should welcome the reduction in assessments, raise concern about the 65.8 million debt, and do further work via a masterclass to understand that, and particularly to understand, to hear lived experience voices of receiving large bills? Peter, any?
Chair, I think it's an excellent report which shines a light onto this area. Obviously, CQC will claim credit for it, that it was their idea, and that it's been worth shining a light on. I think actually what it lends to in the discussion this morning is it's a really helpful area to almost have a standing annual report that deepens an understanding about people's experiences of using the service. It will be contested, so Lisa's right to indicate it's not easy to always reduce complaints, but again, being able to drill down into what are those about, have a broader understanding, because I think CQC's inclusion of it reflects what they've picked up during their first wave of assessments of councils, that it's an area that causes a lot of concern for people. So I think having an angle on that you've secured, I think would be really important. A byproduct of that is absolutely to have a masterclass on understanding debt, which reflects the complexity of our failure to reform adult social care and the whole range of charging mechanisms, debt profiling that goes with that. So I think is actually to understand it, to look at it both in terms of what risks that exposes to the council, but also I think about what that requires in terms of future profiling, because while social care remains kind of waiting a decision, that the appetite of the council to increase debt is vital to kind of keeping a flow for people. And in the context of LGR, that's an important thing to be able to project for incoming administrations as well. So I think it would be really useful to take that debt profile and have a look at it from a range of angles. But as I say, I think also to build on the work that's been done to capture it into some sort of standing annual report and that takes a really good view of the whole issue.
Thank you. I'd like to add that to the recommendation that we have an annual report.
Great strength.
Thank you, Peter. Councillor Julian.
I'd like to second that, Chair, so we can move forward with it. That'd be fantastic.
Any other comments? Councillor Hookway.
Thank you, Chair. So again, going back to my question about how assessments were made, for me, the key answer was the use of the JAX system, which is coming along. I sit on the JAX subgroup. The JAX is going to be a huge development within this authority and how it acquires data about people and how it uses that data. And my concern at the moment, for this committee anyway, is that in my division and neighbouring divisions, there are a very large number of residents who are elderly. They're in their 80s, they're in their 90s, and online assessments will be something that will be very difficult for them to do. Therefore, I think that this committee, based upon the report, should be making recommendations not only to Cabinet but even to the Corporate Infrastructure Committee that there are concerns about this, and then we need to make sure that as the JAX system is introduced, there are methods and systems in place that allow the very elderly people to, the very elderly residents to access the new JAX system. We need to design this in from the beginning. It's no good doing it after we've started. We need to think about this. So we need to raise that there is an awareness about these assessments to Cabinet and to other scrutiny committees, and therefore be proactive in the adoption of this JAX system and to ease and the flow of information, and perhaps even make the system a little bit more efficient. Who knows? But anyway, I just wanted to raise that because I think it's an important point that with JAX coming in, it's such a huge change that we really must be making people aware of our concerns. Thank you, Chair.
Thank you. Shall we do that through the JAX working group, Councillor Hookway?
Well, we can do if you like, Chair.
Let's do that.
Okay, fine.
Thank you. If we could, shall we? It's incredibly hot in here. So, can we go to the? Is it
about JAX? How does it cope with digital exclusion?
Shall we take that offline? Should we do that and move to the vote? Because I'm just conscious of the fact it is incredibly hot in here, and we can always have a conversation around JAX outside this meeting. Is that okay, Councillor Rogers? Thank you. So if we could move to the vote. So we're going to welcome the reduction in people waiting for financial assessment, raise concern around the aged debt of 65.8 million. We're going to do further work in a masterclass, and we're going to instate an annual report on client financial services going forward for this committee. If we could go to the vote, and that's, I think, been seconded by Councillor Julian. Thank you. I think that's unanimous. Thank you very much. Gosh, it's unbelievably hard. I don't know about everybody else, but it's... So, if we could please go on to item number 8, which is Adult Social Care Customer Feedback Report. So we have Patrick Phelan, Assistant Director of Communications and Customer Engagement. Where's Patrick? Oh, hi, Patrick. And Helen Wyatt, Customer Relations Manager. Welcome. So if you'd like to introduce your report.
Thank you, Chair. I'll do a brief summary. I'll try to keep it quick as it is quite warm. So as you say, I'm presenting the feedback report covering feedback received between 1st of April 25 and 31st of March 2026. So starting with context, reference to section 2.2, important to note complaint volumes do remain low in comparison to the population supported, so around 1%, and set against the overall scale of the service. I think that's very important to share. In reference to section 3.1, around a general overview of the feedback received, the service responded to 206 complaints in the year, 49% of those upheld or partially upheld, and 55% responded to within agreed timescales. Alongside this, 301 compliments were recorded, so there do continue to be more compliments than complaints, which is positive. In terms of trends, complaint volumes have increased over time, both within adult social care and across the council more broadly. Within adult social care, complaints have increased from 161 complaints in the 2022-23 year to 288 in 25-26. So that's around a 79% increase. So quite significant. More widely across the council, just for context, complaints have increased from just over 1,600 to 2,400 in the same time period. So that's around a 50% increase. That small fact isn't in that report. I'm just sharing for additional context for you. Really, this isn't showing any signs of slowing down. A 79% increase in adult social care over that time period is significant, and as we've already heard, is likely to increase in certain areas. There isn't a single confirmed cause for that increase, but could be a combination of factors. That may be increased demand, greater complexity, as we've heard, increased awareness of the complaints procedure could be a very simple reason why people are complaining more. And this increase in volume has also impacted on my team, customer relations team, capacity to progress those complaints in a timely way. Moving on to the themes in section 3.2. Complaints consistently highlight delays in progressing assessments and follow-up, communication and involvement, and as we've talked about, financial matters, some concerns relating to care quality and coordination. Section 3.3, timeliness. As I've already alluded to, performance has been quite variable across the year, improving earlier on but declining during periods of increased complaint volume. Overall performance is broadly in line with last year, but consistency continues to be a challenge in that respect. Important to note that complaint regulations don't specify a fixed response time scale. I think that's important clarity there. Instead, a reasonable time frame is usually agreed by customer relations with the relevant responding manager, and then that's confirmed to the customer. This does mean a greater proportion of complaints could be responded to within agreed timescales in principle. However, where timescales are not met, this can often be because updates around not being able to meet that timescale haven't been communicated to my team, which can then result in those complaints being recorded as out of time. In section 3.4 around ombudsman outcomes, there were 21 cases concluded. 9 of those were investigated and 6 of those were upheld. So those volumes are very small in comparison, again, to the number of complaints that come through the door and the population. But the findings do mirror local complaint themes around delays, communication, coordination and oversight. It's worth noting in relation to the Ombudsman around the annual letters, I thought I'd just give you a brief update. So the approach has changed. Previously, all authorities would receive a bespoke annual letter later in the year, but now only those letters are only issued where there's exceptional practice or concerns around things like complaints handling. Not every authority will receive a letter, and any letters that are issued will be published in July, hence why there isn't a letter to share with you today with this report. We won't know until later if we will receive one. So I mentioned briefly about the impact on customer relations. Again, for context, Chair, so customer relations has been operating with a reduced capacity for quite some time, unfortunately, and combined with the increase in complaint volumes, that's affected how quickly we can progress the complaints coming through the door. It doesn't affect the timescales for response with services because we continue to agree an appropriate timescale with managers, but does have an impact on how long customers have to wait, which I'd like to note. Pleased to say that we have agreed some additional investment in the team, though, so we have some new staff starting shortly, and this should begin to improve our capacity and our timeliness in progressing complaints. So in summary, it's a balanced position broadly, more compliments than complaints, clear evidence of positive practice through those compliments, but there are some themes for improvement, particularly around timeliness and some matters around communication. Thank you, Chair.
Thank you very much indeed, Helen. Patrick, would you like to add anything?
Yeah, a couple of things. First of all, I think we've got to value customer feedback, and as part of that continuous improvement journey that Tandra described. And we've also recently undergone some changes to the communications team so that there are dedicated staff to support adult social care. So we can review both our digital and print content in relation to Okay.
Thank you. Members, questions, comments? Councillor Abbott.
Yes, thank you. Thank you. Thank you for the report. I've just got some small questions on detail. On 2.2, you say that the 1% of complaints is low, but depends on statistics, really. Is it low in comparison with other organisations, or is it just because one is not apparently a large number?
In terms of local authority complaints, generally speaking, they'll run at around about 1%. It does tend to be that. It is a comparison to the population. There isn't national benchmarking around that information necessarily in an easy to understand format, as nobody benchmarks. There is no organisation that benchmarks complaints. So it is information that I'm aware of, and I know Tandra has commented on population in comparison to complaints, so may have something else to add, possibly. No? So there's no formal benchmarking. So we've got an adult social care outcomes framework. We benchmark a range of things, in terms of numbers of clients, what type of services, etc., what outcomes we're delivering. So there isn't benchmarking in that context. And we encourage people to complain. So if we receive contact from somebody, we will always make them aware of the process. So I think, and there's been reports in previous years from the Ombudsman where he's expressed concern that not enough people, he would expect more, but there is no formal benchmarking. I think it's a reasonable comparison to understand the percentage of people in the context of the overall numbers of people that we support, just to understand how many of them are complaining. With 50%, then, we would be having a different conversation, and we still need to learn from the feedback that we're getting. So the point that Patrick made about, so how do we improve our communications? How do we make information as accessible as possible so that if it's charging or whatever it is, or how the care process works, that could help. So all of that learning is valuable, but we don't have a league table of local authorities and complaints.
Okay, thank you. You chose the adjective low, and if it's just a question that this is the case, then 1%. Okay, but it could be 0.1%, I guess. Anyway, if I go on, please, to the appendix. We have three ways of doing page numbers in here. One of them is that this is page 36 of 120. Getting to myself, sorry. So yes, on the complaints and the compensation. Is the compensation the issue which makes it better for the clients? Is it the apology? we haven't got much more we can offer maybe, except time, which is so precious to us. But would an explanation of this is all we bring people in and show them the work that's going on and the dedication of the staff, which I'm sure exists. How much, I wonder, is a sum of money the issue in making people feel better about the situation?
Is this in relation to the Ombudsman financial remedies?
So I'm looking at Appendix 1, LGSCO upheld complaints, and that it's standard in these to have paid individuals £250, £300 for the distress and so on. And I'm just wondering, is this, if the money's the issue, do people feel better when they receive money? Is this a standard set of fees, perhaps? But really, I'm not worried about the actual number. I'm wondering how the receiving a sum of money buys them off as they are now happy with the service that they've received.
So these are figures that are recommended by the local government and social care ombudsman by the time the person has concluded the full complaints procedure. So we are obliged to adhere to their recommendations, and when they recommend a financial remedy that isn't in relation to somebody being out of pocket, so then this will tend to relate to things like time and trouble for having raised a complaint. So it's taken them a very long time to get someone to accept their complaint, or it might be a distress payment, things like that. And the Ombudsman does have clear remedy guidance that they follow, and they encourage local authorities to follow locally as well. I'm happy to arrange for that information to be circulated. It's publicly available, and the Ombudsman does explain their rationale for figures such as 250, as some of has been cited there. These tend to be symbolic payments, so they aren't going to be significant. They are a recognition that something went wrong, in addition to perhaps an appropriate apology or other actions they might recommend for a service. I think it would be down to personal preference as to whether individual customers will accept that or not.
Thank you, Helen. Sarah.
I wonder if I can come in to add to that, because as you quite rightly observe, often the issue isn't about the compensation that's being offered or the payment as compensation for time and distress. But what people are keen to hear is that we've learnt as a result of the complaint and the investigation into it, and other people aren't going to experience the same service that's resulted in the complaint. And that's what really matters to people, actually, and that's what we're able to kind of assure people through the complaint investigation process.
Thank you. Councillor Davis.
Yeah, I just wanted to ask about complaints and how you classify, compliments. So, for example, if you had a reablement member of staff was leaving their client and their client said, "Oh, thank you very much, today's been great, it's been really helpful." Do you classify that as a compliment, or does it need to have some sort of route that it comes in as a communication? Tandra was just saying that you actually actively encourage complaints. Do you do the same with compliments, is my question.
I could probably answer part of that, and I think some of it will probably need to come to Tandra around encouraging people to raise compliments instead of complaints, because that wouldn't be my service that would be making that encouragement. But in terms of classifying them, if my team is provided with something that appears to be a complimentary sentiment about a member of staff, then we will record it as such. So we're not applying any more stringent criteria than that. We possibly wouldn't record a compliment if somebody has just said thank you. But if there's more to the complimentary sentiment behind what's being expressed by the customer, then we will record that against the relevant team. But in terms of encouraging people to raise compliments, I think that's probably more for Tandra to answer.
Yes, good point. We probably don't do it enough, encouraging people to formalise their compliments to us, but we do remember to do it sometimes. And I can remember one occasion we had a cake that said thank you. We took a photograph of the cake that was beautifully iced with thank you on it and sent it into the customer relations team. But yes, we probably need to do it more. But our staff are busy and don't always take the time to kind of remind people to formalise their compliments.
Thank you.
Yeah, we did also make the compliments and complaints button on the website more prominent about a year ago. So I think that's part of the reason we're having more feedback.
Okay, yeah, I just wanted to ask also, do you do a regular sort of feedback survey with all of the clients? Are they invited to do that?
We don't have a survey. You thinking like the family friends survey that our NHS colleagues have. But what we do is focus groups with individuals and we get their views on new policies, so focusing on co-production. So feedback on our communications or how services are designed. But we don't do a general survey. There isn't, I think it's actually every 2 years, a national survey, which the government puts out, which we do perform quite well on actually. And there's also a specific survey for carers as well, unpaid carers. But we don't, as a council, do anything specifically to people who come into contact with us to ask us how it went. Ask them how it went.
Councillor Rogers.
Thank you, Chair. Can I congratulate you on celebrating your 20-year anniversary in May? And thank you for making me most welcome a few weeks ago. What astonished me was the health and well-being care your teams put into each other, because it can't be easy day in, day out, listening to complaints. What struck me was the way you care for your team internally. I thank you for that, because when I came away, I was happy that the health and well-being of colleagues facing complaints day in, day out is respected and followed up with individual colleagues, and you should be congratulated for that. I also want to congratulate on your ability to make sure you serve the most digitally excluded in our county to really help them get the service they deserve and need.
Thank you.
Thank you, Councillor Rogers. And if we could minute the thanks, please, from this committee. Thank you very much. I've got a couple of questions, if I may, please, Helen and Tandra. So the number of complaints has increased, but my question is specifically around the increase in upheld complaints. So I believe that that's risen from 34% to 49%. And I wondered if you could explain why you think the upheld rate has increased.
This is probably more of an operational answer. My brief comment would be it is partially an assessment by my team, so that it could be down to there's just more information in responses that is giving us a slightly different take on those. But I think it's probably more an operational answer.
Thank you.
Can you clarify? Do you mean the local government social care ombudsman? Or do you mean our outcome for our complaints?
I think it's our outcome.
I mean, I think it will be a view as to whether we agree or not. And if we are looking at it objectively at the evidence, then it will just be a reflection that we think that we haven't done a good job in that instance, which is why we agree with the complainant.
Thank you. And so one thing that seems to come back quite often is the timeliness of complying with complaints. And so only 55% of complaints are answered within the agreed timescale. And that's despite complaints being identified as a priority area. And I'd like to understand, is the 55% because of the kind of resourcing challenges within the complaints, the customer relations team, or does that 55% arise because people within adult social care aren't responding in a timely way to the customer relations team?
So I mentioned in my my introduction that while the customer relations team's capacity has impacted on our ability to progress complaints to service, we are still ensuring the managers within those services are have an appropriate amount of time to respond. So the timescale that I'm talking about reflects that agreed timescale. So that doesn't incorporate any delays that my team might have progressing at the moment. I suppose a couple of things. What sometimes a complaint turns out to be more complex, and probably what I was hearing from Helen is we need to be better at getting back to the individual and saying, actually, this is going to take a bit longer. I think we don't collect the delay that's at the customer relations team, and I think that probably is having an impact on the individual. From their perspective, they've contacted the council with their complaint and they want a response to it, and they're not really interested in our internal processes. So we probably do need to understand how long it's taken in the customer relations team, because that does delay. So we're agreeing a time frame based on that initial delay, but we also need to get better. These are going to operational teams, operational managers who are following it up. They need to, because they've got the information. They need to talk to, you know, depending on what the complaint is, to get underneath it. But they're obviously balancing lots of different demands on their time, and sometimes there are an awful lot of questions that will need to be responded to, and we perhaps need to be more realistic in terms of how long it will take us to get a properly comprehensive response to that individual that will satisfy them that we've taken their complaint seriously.
Thank you, Tanja. I think what the chart shows is that some teams perform really well in terms of their timeliness, and some teams perform less well in terms of their timeliness. Now, whether that's because there are, you know, the ones that aren't performing in such a timely way have got more challenges, the complaints are more complex, it's more difficult and therefore more justified, I don't know, but it does seem to be a kind of inconsistency in terms of timeliness. And what I would really like to ask Peter, if I may, is whether it would be reasonable to have a kind of a target for responding within agreed timescales. So we do we? Because at the moment we're only meeting 55%.
So we get spreadsheets every week with how many open complaints and how many are still waiting response. The timelines are individually agreed. So absolutely we need to be doing better, but there is an expectation that we will meet the agreed time frame, but it's not like I think I may be misquoting this, but a standard corporate approach would be within 10 working days, for example. That you can't apply that to adults or indeed children's social care. It's individually agreed, but absolutely we need to, I think what we need to get better at is getting back to the individuals, because you might be talking to other organisations as well. It might not, the information that's required might not just be held by the council. It might require partnership working. So absolutely we are on it. We are working with the team to improve in that area, and we need to do better. But I think we'd have to think long and hard about how we manage that, because all of the agreements are on an individual basis.
It just feels like there's the complaint itself, and then the lack of the fact that there's only 50. Often then what follows on is there's another complaint because things aren't dealt with in a timely way, and that's why, you know, it's particularly important that the timeliness is addressed. And just 55% just seems, you know, understand the challenges, but I just think it creates more, you know, it's fed through, isn't it, into the complaint, then it goes to the ombudsman, and the ombudsman then not only is the original complaint, but then there's the issue of timeliness.
So I think if you look at the ombudsman though, and the number of complaints that he just didn't even look into, and that percentage is of a small number, and so the numbers for the ombudsman are very small. That's not saying that we shouldn't improve in our timeliness, but I don't think you can necessarily link those, because that's not what's coming back from the ombudsman.
Just going to say, worse than not having an answer is, even if you say we haven't forgotten you, but we haven't got the answer, that's better than if people think that it's gone into the ether and it's not going to be responded to. So is there any way you can trigger a you know, we haven't forgotten you, we're still working on it?
We do try to send that information, so we may not have had an update from the service, but we do remember there is a customer waiting for something, so we will try to periodically send a note saying we're waiting for further information. So we do at least provide that.
Councillor Davis.
Yeah, I just wanted to ask whether there was any obvious explanation why the eastern area has over 50% more complaints in community health and social care than south east west.
It'll be population. So if you think about Devon,
Sorry, I missed that.
population. So it's where all the people are. Our largest chunk of population is east, really, east, north and east. And if you look at all of our performance information, you'll see that's where the majority of people that we work with live, and that's you would expect to see it reflected in every other aspect.
Councillor Julian.
Yes, I mean, absolutely, we do need, even if they can't get the message out, if somebody made a complaint, just a courtesy call just absolutely sorts everything out. You know, people want to be felt that they've been listened to, or that it's in work in progress, that they're trying to sort out the complaint, but saying nothing is just a nightmare. And that's what winds people up. Communication is so number one on this, that we do need to get on top of this. Courtesy call doesn't cost much, but it saves a lot. Thank you, Chair.
Thank you. So how do we increase that timeliness, Tandra, do you think?
So I think one of the things we need to do is when you've got a complaint that's more complex than you expected, is to talk to the customer relations team to change the amount of time required. So explain to the individual. So absolutely, it's not just about getting back and saying we've got this. It's also about saying to them, actually, we need to find out this additional information that we either don't hold or it's more difficult to get hold of, and then negotiate that on an individual basis. But in terms of is it transparent? Can I see the numbers of complaints? Can I see the proportion that we're what we would flag red? We get that weekly. So does the chief exec, so does the monitoring officer. So we are working on it. We are trying to improve in that area. But I think one of the things I'm hearing from Helen is a bit more communication between operational teams and the customer relations team, so they can have that conversation with the public.
Thank you. And Helen, would you like to comment on how we can improve the timeliness?
I think it's exactly what Tandra said, that communication is the biggest issue here. I think people are very busy and they know they have to deal with a complaint, and sometimes that point of contact back with my team to say, oh, it's going to take longer, or I need to speak to a certain person, they're off work, or I need more information, or I've got a major safeguarding matter I've suddenly got to deal with. They just need to drop us a line and say, I'm going to need an extra week, 2 weeks. And we can tell the customer, but that is, I think, what's getting forgotten.
Thank you. Any other comments, or should we think about some recommendations? Okay, so in terms of, so I was interested in the discussions with Councillor Abbott and Sarah around what makes a difference to people who've submitted a complaint and a complaint's been upheld. And I wonder whether we should, as a council, have an annual, you said we did report on to go alongside the complaints, so that we can show people how, if there are themes in complaints, we've changed our practice, and the lived experience of people drawing on our services has actually been taken into account. Does anybody think that would be?
I think, Chair, I think that's a good idea. I think we do need to be seen to be doing something about this. I think it's very important. So I quite agree with you, Chair, and I'd second that.
Thank you. Any other comments or recommendations? I mean, I would like to make a recommendation around prioritising the timeliness of I know we already are, but to try and so that the timeliness increases, so that we make that a priority. Any comments on?
So I think what we probably need to do is have a conversation outside of this meeting to work out who's going to be writing the "You Said We Did" report and what we can do in terms of timeliness. But absolutely, we can take that away and confirm to you what the approach that we'll take.
Everybody happy with that? Should we have a vote? Thank you. Thank you very much. Thank you. Okay, so item number 9, NHS dental services in Devon. So I think we have joining us online, lead officer Jonathan Bauer-Davis, clinical dental advisor for primary care commissioning team. Welcome, Jonathan. If you'd like to briefly introduce your report, please.
Thank you. Yeah, thank you for inviting us, Chair. So we submitted the report. Would you like me? I'm mindful of you commenting on the temperature in your room. Would you like me to take this mainly as read and just give a brief summary?
Yes, please.
Thank you.
That would be appreciated. It's
I'm happy to have as many questions as you need. So yeah, the key priorities for dental service in Devon are focused around the national contract reform, which I can touch on in a bit more detail, but making sure that some of those changes mainly focused on areas of increasing access for unscheduled care, which is commonly known as urgent dental care, but also embedding some of the other elements, which are items such as quality improvement. We're also wanting to make sure that some of the good work that's been going on around stabilisation sessions, which have typically targeted those who have higher dental needs and therefore have maybe not been able to access quite as much care as they possibly could under the traditional units of dental activity sessions. So trying to keep those continuing. We've also had great success in mobilising some new dental contracts. So the total for these is sort of over £5 million per year and more than 109,000 units of dental activity occurring a year as well. So these are spread across Devon, from Plymouth, Torquay, Barnstaple, Bideford, Exeter areas, and those are going well in terms of having been awarded in March and looking to move forward. There's also been a new orthodontic service that went live in April 2026 for North Devon and Torridge, which is receiving lots of good feedback. We've also been focusing on vulnerable groups. So those procurements I've just spoken about, we've been working with providers to ensure that they can look at ways of improving access for various inclusion health groups and vulnerable groups. We've also been maintaining commissioning of preventative activities such as supervised toothbrushing, an open wide step inside. And then finally, we've been doing a big push on dental workforce. We know that workforce retention and recruitment is one of the biggest barriers to delivering contracted activity across Devon. And so there's been a number of pieces of work that have looked at addressing that. So we have an ongoing workforce strategy group that's supported areas such as developing a new Devon dental workforce webpage alongside external stakeholders like the local dental committee, and this is allowing dental providers to post various vacancies at one easy to locate webpage for anyone interested in working in Devon. We also, as NHS Devon, managed to secure a stand at the British Dental Conference and Dentistry Show in Birmingham in May, and we had at least 40 expressions of interest in ongoing employment opportunities in Devon, which we're chasing up and hoping to link those individuals up with potential partners delivering dental care. We've also continued the national Golden Hello recruitment scheme and looking at actively recruiting 15 posts at the moment and have successfully recruited 4 posts across Devon. And then finally, we've been looking at a couple of bursary and funding options for postgraduate training. So there is a scheme that will assist the dental workforce with undertaking and progressing their skills at Bristol University and Peninsula University, and also supporting funding for specialist dental trainee posts, whereby we want to help support and allow for a resilient specialist workforce in Devon. Sorry for the quick summary, but mindful of the temperature.
Thank you very much, Jonathan. If I could go to members now for any questions or comments for Jonathan about this report. Councillor Julian and then Councillor Roger.
Yes, about using the toothbrush. Is this going to be rolled out to the nurseries? Because it seems to be a big thing that children not cleaning their teeth, because obviously you want to try and sort of save their teeth, these children, and it should be everywhere to promote cleaning teeth for the children. I think is really important, because some of the children that get to nursery never clean their teeth. So I think it really is critical that we promote this really vigorously to save the children, basically, on the dentistry. Thank you. Just your comments, please.
Yes, so absolutely. Prevention is something we work very closely with local authorities on. So there are several different programs focused on particularly children's oral health prevention. So there's First Dental Steps, whereby we're working with health visitors to make sure that they can help give the appropriate messaging. Supervised toothbrushing is targeted at 3 to 5 year olds across all nurseries and school in Devon. So at the moment we've got 44% of schools currently participating. We're helping to push that up, but that's over 11,500 pupils brushing. And then also Open Wide Step Inside, which we fund, which is sort of targeting 6 and 7 year olds. And there's 71% of Devon schools participating in that at the moment, funded by NHS Devon.
Thank you, Councillor Rogers.
Thank you, Chair. Do we have a map of where the dental deserts are around the county? Shall I just read my questions first and then? Do we have any data as to the cost of living impact on dentistry across the county? And within the map, what is the issues and solution for rural communities to access dentistry?
Yes, so in terms of sort of mapping dental services, one of the challenges we've always got is, unlike GPs, there's not sort of a registered list of patients with a dental practice. There's the dental contract does not allow for that, and therefore it can be quite challenging as to determine which patients are attending which practices, and therefore mapping. But absolutely, in terms of mapping out where local providers are, that was one of the focuses of that procurement of sort of more than £5 million worth of dental activity each year, was targeting on areas where we believe there probably was less access available. So it's been targeted on that basis.
If I could just make a comment about the report. So the last time that we had this committee had a report was in 2023, and that showed that nearly 59,000 people were on the waiting list, and that it also set out that staff workforce shortages were one of the key constraints. What I find with this report is there's very little actual data about waiting lists and the challenges that the people of Devon face in accessing a dentist, an NHS dentist. And following on from what Councillor Rogers says, we don't get a sense of where those issues are specifically. There must be areas in Devon where it's harder for people to access dentists. So I would like to know, please, how does Devon compare with the England average for adults and children seen by NHS dentists in the last 24 months? I believe that our access to dentists are is less in this part of the country than elsewhere. So I'd like you to comment on that, please. And if you could explain why there's no data in the report around accessing dentists. I understand what you've said around there being no kind of formal lists, but we must know, surely as a commissioner, you must know as commissioners what's happening to the residents and the residents that can't actually access dentists. Thank you.
Yeah, so thank you. So just picking up on a couple of bits in there. So the recruitment bit, that's why it's focused, and certainly at national level, there is a drive to improve the dental workforce. So there's work going on with the General Dental Council in terms of the number of places at dental schools, but also the availability of the overseas registration exam, which would allow internationally trained dentists to come and be registered and work over here. So there's work going on there. In terms of access rates, I have got some data around that, thanks to one of your colleagues sort of flagging some queries on Friday that we've pulled out. So as of the end of Q3 for 25-26, 26.1% of all unique adult patients were seen by dentists across the previous 12-month period, and 52.7% of unique child patients were seen by dentists across the previous 24-month period. And in terms of how those figures compare with previous years, between financial year 24-25 and financial year 25-26, total unique patient activity fell by around 8%. So that's from approximately 430,000 to 394,000, which continues a downward trend in access. The downward decline is almost entirely within adults, whose numbers fell approximately 36,000, while child activity remained effectively flat at around 127,000. I'm just trying to pull out any further information about that. Overall population coverage dropped from 35.6% to 32.6%, which is a widening gap in access. And some of the changes, particularly around the national dental contract reform, is focusing on this. So one of the items that's embedded and hasn't been part of the dental contract up until April has been quality improvement elements, and so the focus on that from a national level is on the recall guidance and ensuring that effectively practices have got the right tools and training to ensure that where patients manage to access the dentist and are seen as low risk, that rather than being seen at, say, a sort of 6-monthly regular basis, the guidance supported by the evidence base is that actually their recall interval for a dental checkup can be extended up to, say, 2 years, and that in itself should generate, we've seen some information from Wales, but it should allow more individuals to access dentistry, and for the allocation of service capacity to be more focused on those that are of greater need.
Thank you. So you're saying that it's gone down by 8%, Jonathan, in a year, is that right?
Yes, I believe so from the figures I've got.
Okay. Members, any comments or concerns? Councillor Hootway.
Thank you, Chair. I agree with your comments about this report. In fact, I would go a bit further and say that it's fundamentally unsound. It does not provide us the information or give us the picture. I think there's no doubt about this. There is a clear postcode lottery in this county if you want to gain access to a dentist. It's all very well saying things are improving, but the measure of improvement is very low. I have an old friend of mine who was a dentist. He's now retired. He is scathing about NHS dental services, and blames Tony Blair, who changed the contract and completely effectively destroyed what was a reasonable dental service. It wasn't perfect, but it was better than where we have now. As a layperson, everything I hear about dental health indicates that looking after your dental health is one of the most important things you can do for preventative care. Therefore, it seems that we are not doing anything in the way of improving dental care. There seems to be a lack of a strategic overview or planning, and I think we ought to consider trying to develop an action plan for Devon. This council needs to do something more. We need to get government involved, we need to write letters of protest, and we certainly need to try to do something much more effectively. So I have one particular, or two particular very short questions for Jonathan in terms of the contract. Are you collecting key performance indicators on this contract? And would you share those key performance indicators with us, please? Thank you, Chair.
Is this specifically on the general dental services contract, sort of typical high street dentistry?
Yes, please.
Yes. So yeah, nationally there are set performance indicators that fit with that. So a lot of that is managed by the Collaborative Commissioning Hub, and looking at in terms of delivery of your overall unit of dental activity contract, how many units of dental activity are performed against what's commissioned, how the breakdown of that is in terms of most dental treatment is banded into various categories. So understanding what the distribution of that banding is, what patients are coming through with that, and then with the new national contract reforms, as of tomorrow, one of the major elements for this year's reform is complex care pathways, and that is going live tomorrow following an update last week about the details of that. So I believe there will probably be some other metrics that are associated with those complex care pathways.
Sorry, thank you for your answer. I didn't hear the phrase key performance indicators. Are you collecting key performance indicators, yes, and will you share those with this committee, please? Thank you.
Yes.
Thank you. Jonathan, so we've got more than 20% of 5-year-olds in Devon with tooth decay. That's on page 39. But the community dental services didn't carry out the fieldwork survey for the 24-25 oral health survey, which included, I think for 25-26, a survey of 5-year-olds. So why was that not completed?
The epidemiology, that was primarily workforce challenges. So again, we are working with partners. So a lot of the workforce enhancement work has been beneficial. So actually, I'm of the understanding that Live Well are now fully recruited into their dental team. And so yeah, that should support them for doing this. And certainly across the Southwest region, we're aware that some of the epidemiology delivery has been particularly challenging within community dental services, because they have probably faced some of the more severe recruitment challenges across the patch. So yeah, we're trying to work with them to support that.
So was it down to Live Well that survey wasn't completed?
I am not, in my sort of capacity of sort of clinical advisor for the ICB, I'm not aware of the details of elements of that, because I know particularly around epidemiology, that's something that sits between sort of us as the ICB and local authorities. So I'm not sort of aware of the details of that particular case.
Thank you. I'm going to go to Steve Brown, Director of Public Health.
Yeah, there you go. Thank you, Chair, and thank Jonathan for the report. Just picking up on the epidemiological survey, so that's the responsibility of local authorities and the public health team. And Jonathan's correct. While we ask our providers to do it, they come back and say they don't have capacity. Even if we've offered additional finance, they still do not have the capacity to do it. And as Jonathan said, it will be taking people off the front line to do that. So it's really disappointing. We don't have the details of the year 5, so the 5-year-olds, or indeed the older adults.
This coming survey is for 3-year-olds, and I think our degree of confidence, hopefully Jonathan emphasised this, is that they will have the capacity to actually do it this year, undertake that. The survey contributes to a broader survey across the country. What I will say is there's a significant straight line, more or less, correlation between deprivation and the poor teeth of our children. So if you want to know where the kids are, you have the poorest teeth, you find the poorest area, and that's where. So the interventions, which are described in point 123, they are targeted at those areas in greatest need, i.e. those areas of greatest deprivation, because we know exactly where those children are. It is disappointing that the survey for the older adults wasn't carried out, but you'll see in the report we are doing some work, as you will probably appreciate. It's great to have the preventative bit for our youngsters, but also we know the teeth of our older adults, particularly those in vulnerable care homes, is really, really important in terms of their hydration and nutrition, but also their well-being as well. So understanding how we can support the staff within our care homes to think about oral care has been really, really important. It's crucial as well.
Thank you. Peter, would you like to say anything?
I think essentially it's around holding the ICB to what I understand to be their core purpose, which is strategic commissioning based on population health need. And while Jonathan set out a whole range of initiatives, it's what's the impact of that on altering the way in which you're meeting need? That makes sense. And I think that's that. It's about trying to get that profile and being able to show that, particularly, I think, given the emphasis put on preventative aspects that arise, as I understand it, through public health and auditing. That's always helpful. The preventative side of it and how you could amplify that.
Thank you. And so for me, I'm not fully clear actually, because of the lack of data within this report, the scale of the challenges, where those challenges are within our county. We believe that they're particularly in areas of deprivation, but we just haven't got that information in this report, and we haven't. So you've kindly today given some figures, the reduction in number of people accessing dentists over the last 12 months, but I do think we need a fuller report from the ICB, particularly because of the financial challenges of the ICB, and how is that also going to potentially impact the services that are commissioned. So I don't feel personally that we have sufficient information from this report to actually evaluate and scrutinise dental services within the county. So I would request, and I'm looking at my colleagues now, that you come back to our next committee with a full detailed report setting out, and I'm sure that we can between ourselves send you some more questions about actually what we want to be answered after this meeting, but it needs to show clearly where the challenges are in our county and what you're specifically doing to overcome those challenges and to increase accessibility to dentists, and where the poorest areas of access are, and what mitigations and initiatives you're introducing specifically in those areas to improve access to dentists. And I really am upset that our 5-year-olds weren't surveyed, and I'm really concerned that 20% of 5-year-olds in Devon have tooth decay. So whilst I hear what you say, that there hasn't been a downward decline in the number of children that are accessing dentists in Devon, I'd like to see that increase, as I'm sure my council colleagues would like to see that increase. So can I politely request that we have a further report for our next committee, and you can remind me of the date of our next committee, but that sets out those points that I've mentioned. Is the committee happy with that? Yeah, thank you very much. Thank you, Jonathan.
Thank you.
Our next meeting is the 14th of September, so if a full report could be provided for that, I'll be appreciated. Thank you. So moving on now to item number 10, NHS Devon, ICB and RDUH financial pressures. So I'd like to welcome, please, we have Peter Collins here from the ICB. We also have Gary Henage from the ICB online, from the ICB, and also Sam Higginson from the RDUH are joining us online. Thank you, everybody, and welcome. Who would like to go first?
Chair, I think Gary will be introduced in this item in his capacity as Acting Finance Director for the ICB.
Thank you. Thank you, Gary.
Yeah, thank you, Chair. So, so the paper in front of you gives the update to the NHS Devon planning process, which you'll see as yet to be concluded. I will take the paper as read, if I may, Chair. I'd probably just like to highlight a couple of points and then maybe bring others in. So our focus continues to be on closing our efficiency gap and developing the schemes till we get to fully developed. Progress is continuing on those, and we've got clear targets across the system to close the remaining gaps. And then you'll see we've also put in place what I'm saying is enhanced oversight arrangements, building on what happened last year. I'll pause there, Chair, and happy to take any questions before others may want to come in.
Any questions?
Thank you, Chair. In our first page on agenda item 10, you quote a deficit of 286 million. Do you have a breakdown of that deficit by hospital?
We do, and I can forward that separately if it's helpful. If I haven't quite got it in front of me, no. So, but happy to share that separately with the committee.
Thank you. I mean, that is a huge amount. And we're now in towards the end of June, and the financial agreement for 26-27 hasn't been agreed with NHS England. So councils always have to do a balanced budget at the end of every year. So how close are you to agreeing that with NHS England, and what are the barriers to agreeing it, and why hasn't it been agreed?
So let me try and break that down a little bit, if I may. So we've had in place across the NHS for the last few years what is regarded as, and I think this committee is aware of, deficit support funding, so DSF, and that is to bridge short-term gaps in funding whilst we address our underlying cost base. You quoted earlier the 300 million. This system has had a 300 million underlying challenge for a number of years, and the only way that is going to get addressed is if we generate recurrent cost savings. And this system has over-relied on non-recurrent previously, whether that is deficit support funding or non-recurrent efficiencies. We are, as I said, we are in the process of agreeing that with NHS England. I think we are very close to agreeing that, and we're waiting for a formal sign-off letter from NHS England, which will confirm the 26-27 position.
Thank you, but can you explain to me, so going forward, which services are at risk if so from saving the money going forward? Which services within, how are you going to save that money going forward?
So each organisation will have its own plans, and I don't know if Sam wants to come in at this point and just talk briefly about the RDH position, but each organisation will have their own plans as well as the ICB, and that'll be made of kind of two main elements: what we call BAU efficiencies, so that's efficiencies that we need to do, and then there'll be an element of transformation efficiencies that again this system needs to focus on. But let me just bring maybe Sam in to answer that question, if I may, Chair. Thank you.
Hi, good afternoon, everyone.
Sam.
My name's Sam Higginson. I'm the Chief Executive of the RDUH, and I met many of you at a previous committee when we were talking about 25-26 So to just try and put a little bit of local flavour on it for East and North Devon, we finished 25-26 with a £44 million deficit against an initial break-even plan. But we have now agreed a break-even plan for 26-27 with NHS England and the ICB. That means we will need to deliver £80 million worth of savings this financial year and also reduce our workforce by about 1.8%. So to try and put that in context for you, that's about 300 to 400 members of staff across East and North Devon. How are we doing that? We have launched a voluntary redundancy programme, which has just closed. We've had over 500 applications. We are now working through those to understand where can we support those applications or where is it not possible to support those applications because we need to continue to run clinical services. As Gary says, we're also looking at how can we transform our services in line with the 10-year plan. So to give you a bit of a sense of that, the national direction of travel is that we need to move more services out of hospitals into neighbourhoods and communities. So we will be rationalising some of our bed base as we look to deliver more services closer to home, particularly with primary care partners. The other big challenge in the 10-year plan was to move, it's talked about as moving from analogue to digital. So we are looking at where can we move services into a digital format. So to give you an example of that, we have recently moved our outpatient fracture clinic to a virtual format for some parts of Devon. So what you will see increasingly as we aim to deliver this plan is looking at, in effect, where can we deliver the best possible outcomes for our patients, but also the best value for money for the taxpayer. And we're currently right in the middle of a process of identifying our plans. We've got about, I think at the last count, 84% of our saving schemes identified for the financial year. And we've been challenged by Gary and colleagues to identify the remaining portion in the next couple of weeks. So it's underway. It is obviously going to be a very challenging year, both for my organisation, but for the other acute providers in Devon because of the scale of the service challenge. But it's really clear that we've got to deliver these changes in order to bring the health service in Devon back into a sustainable footing. I'm really grateful when I can see her here today for Tandra's support because a big bit of this is working with colleagues at the council around the work that you've got underway with Newton working on no criteria to reside, because currently today anywhere between about 15 to 20% of my beds are occupied by patients without a criteria to reside. So we're trying to work as closely as we can with colleagues at the council to really accelerate some of the changes we know we need to deliver collectively for the patients on those pathways. So, Chair, hopefully that's a helpful summary, but I'm, like Gary, really happy to take any questions.
Thank you. Members?
Thank you, and thank you for the update. Within your cost to save money, is cardiology at Torbay going to be subject to cost saving? And what are we telling residents and resident expectation about their care within the NHS in Devon?
So cardiology at Torbay is delivered by Torbay and South Devon Trust, not my trust. My trust is responsible for East and North Devon. But all of my services are being reviewed to look at how we can transform them. And that's particularly the case for outpatient pathways. So to give you an example of that, for cardiology services in East and North Devon, we've just introduced ambient voice technology in all of our outpatient clinics. So if you go to one of my outpatient clinics, you will now find the clinician is looking you in the face and they have a little microphone that is collecting all of the conversation using AI and then automatically producing the patient notes that the clinician can then verify. That's allowing me to put an extra cardiology patient on every single one of my outpatient clinics. So there's a big productivity opportunity there. So certainly for me, cardiology, like all of the services, will be part of a big change programme.
Thank you. And I can see Peter Collins has put his hand up.
Thank you, Chair. And I just wanted to add to Sam's point that to deliver the maximum value for patients across our population, we have to make sure that we are standardising our pathways, and we know that there is a lot of waste that's in the way that we deliver care when there is difference between one provider and another. So in direct answer to your question, we were reviewing all services across all of our providers in Devon to make sure that we are maximising the efficiencies that Sam has mentioned, so that we have standardisation and the best access we can within the financial envelope we have to all of our population.
Thank you. And can I ask, bearing in mind the financial pressures across the whole system, the whole NHS, are we expecting to see significant service changes and consultations during 26-27?
So it would be wrong, wouldn't it, of any of us to shy away from the fact that with a deficit like that, we don't need to provide fundamental changes to services. And I think we need to do that in dialogue with our population and with elected members. So you will see us, I think, as Devon, Cornwall, the Isles of Scilly ICB cluster, coming out and having more dialogue with you about the services that we think we need to change in line, as Sam has said, with the 10-year plan, the move from hospitals to community, from ill health to good health, from analog to digital. All of that should improve services, and it is really important to remember that the financial problems that we report here are a symptom of us not providing services in the best way possible. They are not the cause.
Thank you. Members, any questions? Councillor Julian.
Yeah, thank you, Chair. With the big cutbacks and reducing staff, being North Devon, which is, demographically a very difficult area to, with the travelling and everything. So are we going to be more efficient? Because we talked about this last year, where we'll be more efficient if the people can leave the hospital, they could get into a community or a community hospital, or whatever hospital you want to call it, and then straight home. Obviously not the severe ones, but the ones that are capable, to be more efficient, where they're caring and everybody's listening to one another. Because if I remember, when we went to one of the hospitals, the communication between getting people out of the hospital, nobody was talking about the patient, and they were stuck in the beds. And I find that we could be more efficient rather than wasting money, being more efficient, so we can move them along a bit smoothly and everybody knows what's going on, because that's where the big backlog is, where we're wasting money, or that we're cutting services. But if we did it that way, we benefit. I just wanted to know what their views are on that. Thank you, Chair.
Thank you.
Councillor Julian, why don't I come in, and Tandra may want to come in as well. So I absolutely agree with you. In North Devon currently, at any one time, as I said earlier, somewhere between about 15 to 20% of our acute beds have patients in them who without a criteria to reside. And what we mean by that is they're medically fit, but we need to support them on the next phase of their care pathway. And currently we have not optimized the system. So we have not got enough of our patients going home to be supported to live at home. And we've got too many of our patients going into nursing or bedded care. So we absolutely recognise that is a collective problem, and we need to do some work on that together with Tandra and her team. We've been running a series of events to look at how can we improve some of our processes. So we've now got social workers working much more directly on the wards with my nursing teams, and that is definitely helping. I think we also recognise there's a job of work we need to do with our community beds. So we've got some great community bedded facilities, whether that's in South Molton, Tiverton, Exmouth, Sidmouth, but we need to look at how can we really optimise that capacity so we're rehabilitating our patients and getting them as home as quickly as possible. So I think there is a big opportunity there that we need to unlock together.
Can I come back?
Should we go to Tandra first and then, is that okay?
Sorry, I just want to come back.
Oh yeah, okay.
Sorry, Chair. If you can come back and give us a good feedback that they are actually doing that through us, through the panel, so we know exactly, we can talk about it, but if we can actually see it, it'd be absolutely fantastic. Thank you, Chair.
Thank you.
Thank you, Chair. So we've come and spoken to you about Living Well in Devon and our strategic partner Newton, who are helping us transform a number of key areas within adult social care. One of those is around hospital discharge pathways. And as Sam has just outlined, we've got social workers back on the wards working with teams. We're also putting significant input into helping unlock people who've got stuck in hospital discharge pathways. The ultimate aim being to get as many people back home as possible with the right amount of care that they need, because what we'd seen was our numbers ending up in bed-based care had significantly increased. So you won't see the impact of that work immediately, because it takes time for us to get through the numbers of people that we've got to work with. What we are trying to do as a partnership, so with the RDU and with the ICB, is look again at the commissioning of the hospital discharge pathways. And we've got variable arrangements in at the moment, including a significant amount of beds that are spot purchased. So if you can imagine from an operational social work perspective, that's really hard because Devon is big, getting round to all of those places. So we need to come up with together as a system, a better way of commissioning hospital discharge pathways. We want to see more people going home with the right amount of care, so continuing to live independently. For some people, going into bed-based care or going into nursing care is going to be the right outcome. And what we haven't got right yet is that rehab approach to people. And the conversations are at the moment about what should the location be for that bed-based care? How do we ensure that the right therapeutic support is in place for them? And, is it in a community setting or, and how much of it could be rehab in the home, for example? So one of the things we've also done, and we're seeing really good results from it, is our own reablement team has increased capacity and they're working with more people to help them become more independent. But we need to do more as a system. So we don't have all of the skills. So we need to work with our partners in the NHS to think about what that might look like. And I think that's at the moment where we're working through. So we need to come up with that solution. And there's definitely a lot of commitment from ourselves, from the RDU and from the ICB. And I don't know whether Peter is going to be able to comment, but I think what we need is as a collective to agree, what does that new commissioning of that pathway look like? So we all agree there's a problem. We sort of know what the solution is, but we haven't bottomed it out. And from the person's perspective, the sooner we get to that, the sooner we'll start to see the numbers of people who go into bed-based care reducing, but also that flow from the hospital out into the community will improve as well, because we'll have be spending more intensive time working with people and helping them get back home.
Thank you, Peter.
Thanks, Sandra, for that introduction. And I think one of our key focuses as we move into the next year and the next 3 years will be about how we develop a true model of neighbourhood health delivery. So local services that help keep people at home and are better at receiving people back into their homes, and working with local authority partners, with our voluntary sector partners. We are committed to finding better ways of doing that more quickly so that patients spend the least time possible in health services, and when they do, they get the services they need and deserve.
Thank you, Peter. Councillor Hookway.
Thank you, Chair. Question for Sam, please. I note your policy to get people out of hospital into their homes as quickly as possible. That's something I absolutely support and agree with. How getting them out of the hospital to their homes may be an issue for some. I've received feedback from residents on the passenger transport system. Service is actually consistent, erratic, and reliable. So can I ask you if you would investigate that, please, and report back to the committee later on, because it is a real concern to those patients, some of whom are incapable, that they sometimes cannot get to their outpatient appointments if any PTS doesn't deliver. Thank you, Chair.
Thank you. Sam?
So, Chair, I'm sorry, the councillor's question slightly broke up, but I think the question was a concern about the unreliability of the patient transport service. If that's, you're
Yes.
nodding. So let me pick that up and I will take that away with ICB colleagues and we will look into it.
Thank you. Any other comments? Oh, Councillor Rogers.
As a county, when we discharge someone from a hospital, do we have data as to what residents have care plans? And when travelling home on whatever mode of transport supported by the hospital, if someone is on their own, are we confident that when that person goes back to their home, there's a process in place to check that person will not be readmitted to hospital and they've got access to key services like drinks and refreshments and food as a county?
So the short answer to that is we work as system partners to ensure that we've got that information in place, and we're actually looking at how can we support people and stop readmissions and where have we got further opportunities. So to give you an example, we've been doing some work in Torrington around the end of life pathway recently, to support patients to be able to stay in their own homes where they wish to do so when they're on an end of life pathway. And a lot of that is around ensuring that patients have got access to pain relief and ensuring that we've got timely documentation and we can support them with their needs. So there is a lot of work in that area. That's not to say that we can't do more, which slightly links back to Peter's point, that if we're going to deliver a vision of better care closer to people's homes and supporting people in their homes, we do need to improve our coordination of information and ensuring that we're monitoring people appropriately. I currently run a 100-bedded virtual ward across East and North Devon, which is about 85% occupied at any one time. So at any one time, I will have 85 patients in their homes being monitored using wearable technology, and that data comes directly back to the trust. And so if there is an alert, we will then proactively contact those patients or send a neighbourhood team to support them in their own home. So potentially we're in an exciting step change in all of this, where we will be able to support more and more patients in that way.
Thank you. Councillor Cox.
I'm a chairman of a food bank and volunteer for the food bank. We have been asked by the discharge teams to provide food for people and drinks, because I understand, it's great when you get home and there's no milk, and if you're being so I guess the discharge teams in the hospitals are sorting that out, and they obviously use the food bank on occasions.
Thank you for that.
That's correct. They do, Councillor, on occasions use the food bank. We also rely a lot on different groups of volunteers in different parts of the patch to support patients in those crucial sort of few hours when they're arriving home, to ensure that we can support them.
Thank you very much. I'd like to thank you today for your report and attending, and really request that you keep us informed of the financial situation, both of the ICB and the RDU, and particularly that if there are any service changes planned, and I hear what Peter has said, that we're involved at the earliest opportunity, because I do feel that there may be changes coming soon, and so I'd really appreciate if this committee could be involved at the earliest opportunity. Thank you. Don't know whether anybody wants to add anything else to that. Nope.
breakdown by hospital chair.
Oh, yes. So if we could have that information, please, Gary, for the savings per hospital, that would be appreciated. Thank
Yeah,
you.
will do. Thank
Thank
you.
you very much. So it's getting hotter and hotter in here. So now,
Excuse me, Chair.
Yeah.
Could it be possible to leave the door open? Get
yeah,
some breeze
sure.
now?
We just closed it because it was a bit noisy outside, but. Okay, so item number 11 is a report from on quality accounts. I don't know whether anybody has any comments. That's really for noting. That's item number 11. Councillor Abbott.
Thank you. I just wondered how the access to 4.7 and 4.8, bullet point 3, how has access to defibrillators actually improved? So the claim is made, but I wonder what the practice is. It's unsupported.
So we can certainly take that up and ask that question.
And I have another one then.
Which we can also take up and ask.
So at 410, I wonder whether there's an unintended consequence of reducing handover times by using the pharmacies. Are the pharmacies? No, I'm sorry, I'm mixing up 11 and 13. I need to get to this point. Please excuse me. Or 10, if I can get to it. I shall ask you later, Jess.
That's absolutely fine, Councillor Abbott, and then we can take up the questions with the appropriate trusts and then circulate the questions and answers to members of the committee. Thank you. Councillor Rogers.
Thank you, Chair. My only question was for 4.7 was, do we have a list of defibrillator black spots across the county?
I don't think we do. I don't know where, is Steve Brown? Is anybody from Public Health here?
Sorry, Chair, Steve's away dealing with the extreme heat situation as Director of Public Health, so we're quite concerned about what's happening, so that's where he's going. Apologies.
Thank you. So we can check that. We can go and ask Steve Brown afterwards. Thank you. So, Councillor Abbott.
For clarity then, 4.10, second bullet point, the handover times have been reduced by 50% from 125 minutes to 44 minutes. I just wonder whether there's any consequences that was not foreseen in that procedure, or is that just all to the good?
I can't answer that, but we can certainly find out an answer for you. Thank you for raising that. If there's no other comments on the quality accounts, item number 12 is the Standing Overview Group Adults Transformation Programme. That's for noting, and unless anybody has any specific comments.
My comment was linking it to housing, and I note the work being done in Somerset. They are linking adult and social care to housing. I think that is an important part of trying to improve people's lives.
Thank you, Councillor Rogers. I totally agree. Item number 13, adult social care visit to Abbey Rise in Tavistock. I'd like to personally thank the officers of Abbey Rise who took the time and trouble to talk to us and show us around. I found it really informative. So that's a report for noting if anybody wants to make any comments. I'd also like to thank the members that joined me on that. Thank you.
Thank you, Chair. Yes, I thought it was very interesting about how they were sorting their system out there, and I think we should take that on board. I think it was very good. Thank you.
Thank you, Councillor Julian. So moving now to item 14, health and adult care general update. So if I could go to Councillor Keeling.
Thank you very much, Chair. I won't keep you. This is a composite report and for your consideration. Thank you.
Thank you. And a composite comment. So if we could go over to members now, please.
Thanks, Richard. So this is what I was mixing myself up with earlier. So the 5.34 just talks about the expanded pharmacy service, and I wonder in what way is it expanded, and mentions free blood pressure checks. We can do that with our libraries now as well. And has it been expanded with more pharmacists? Is it well supported? Are they overrun themselves?
Peter.
I'm happy to help if that's helpful. So the Pharmacy First programme is a national initiative to expand what your local pharmacy can do in terms of provision, both in treating minor illness, but also, as we know, every contact counts. So I applaud the fact that your local pharmacist can do it and your library can do it, because that means it's more likely that somebody will do it. In terms of blood pressure checking. So I think that this is an initiative that the county can be justifiably proud of. So whilst I would recognise that we still have some access issues to pharmacists, particularly in our hard to reach communities, we work really hard to make sure that we're providing the right contractual incentives for pharmacy colleagues to expand their services, which will in turn adds to that neighbourhood health delivery that I was talking about earlier, and it frees up appointments in both our primary care services, but also it stops people having to go to their local hospital because of all the travel restrictions that we have. So I think it is a good news service. I don't think that we have seen negative impacts in terms of pharmacists not being able to fulfil the commitments that they've promised.
Thank you. Councillor Julian.
Yes, the pharmacists, I think, are wonderful for people to go and see them. However, we've had a sad case in Bideford where we've got a big pharmacy there that the driver that had to deliver all the medical stuff to the pharmacy were constantly hounded by the parking warden people there. And in the end, the company decided to close this big pharmacy down. They wanted to be there. One of the people were coming there like nobody's business, and they closed it down because of the cost and the harassment we had from the park. And I think that's sad, because it was nearly passed by Councillor Barry. He had it sorted. And they said, we've had enough and we can't get them back. They just walked out. And, you know, we're desperate for pharmacists. And I think that's a sad case, Chair.
Thank you for mentioning that, Councillor Julian. Councillor Rogers.
Thank you, Chair. My question is about vapes, and the fire service are concerned that where vapes are being disposed in the rubbish, that's causing a fire risk. And can we work out the best way to raise awareness how to dispose of vapes? Because that is an issue that is going to cost everyone money and potentially lives.
Thank you very much, Councillor Rogers. We'll pass on your concerns. I know that we're well aware at district, when collecting rubbish, the hazards of fires on vehicles, and it has happened. Yes, thank you for that.
Thank you. I've got a question for Peter, please. I'm referring to on page 80, paragraph 5.18 and 5.19. And it talks about NHS England currently consulting integrated care systems on plans to merge clustered integrated care boards into single organisations by April 27. And it goes on to say at paragraph 5.19, As part of this national consultation, we are engaging with local partners across Devon, Cornwall and the Isles of Scilly to understand your views on our proposed footprint and the potential implications for local systems and communities. So my question is that this committee has engaged with the ICB chair and made its views quite clear on representation on the board. And what I'm not clear about, whether those views have been communicated as part of this NHS England consultation, whether our views have been communicated to NHS England.
Thanks, Chair, and a complex question which I'll attempt to answer without overstepping the boundaries of my area of expertise or knowledge. So the consultation that NHS England is engaging in with ICBs is around the footprints of merger. And it is, and the word consultation is probably not the right label to use. It is an assurance process to make sure that ICBs and ICB clusters have engaged with their partners to understand the implications of moving to a single organisation over multiple local authority footprints. And for Devon, Cornwall and the Isles of Scilly, that is a relatively simple process because we have local authorities that already are contiguous with our own population boundaries. For some ICB clusters where there are local authorities that might sit in other ICBs, that becomes much more difficult. So the aim of the NHS England consultation is to understand what those footprints might look like, rather than for colleagues to express concerns about what the future operating model of a single organisation might be. Although, of course, we as an ICB would want to listen to all of our colleagues' views and try and understand them. And that I know, and I don't know whether Donna would want to comment, but that will be the focus of ongoing conversations, particularly through our chairman and chief executive.
So is your understanding, Peter, that so at this stage they're consulting or seeking assurance on the extent of the boundaries, and following on from that, there will be a consultation, a further consultation as we know it?
No, so I think the decision about ICB organisational form is a conversation for, or is a decision for NHS England and the Department of Health and Social Care, as they would see it.
Thank you. So my understanding is that our chief executive is, as per our previous discussions, seeking a meeting with the ICB to further discuss this matter.
There's an executive discussion taking place on the 2nd of July. It's an extensive executive session. The session that had been planned was cancelled until that session takes place, and that includes executives across Plymouth, Torby, Devon, and a joint position and need for an executive discussion to look at structures prior to a session with wider stakeholder group.
Thank you very much. Councillor Rogers.
My question is to the Chief Executive. What support do you need from us as a committee to represent your need to be around that table?
I'm happy to keep the committee updated. I think back to previous agenda items, I think your scrutiny on the budgetary decisions and consultations that may lie ahead in that challenging financial context is where we absolutely need to join up your opportunity to be involved in that governance, along with your opportunity to scrutinise possible implications for the residents of Devon in terms of the scale of the challenges facing a local NHS.
Thank you. Any other comments on the composite? Thank you, Peter. Any other comments on the composite update? Questions for officers? Comments for Peter? No. Thank you very much. So if we could move on to item 15, which is the Scrutiny Committee work programme. Happy to take any comments or questions about that, or we can discuss that offline when it's not quite so hot. Okay, so item number 16, election of champion against domestic and sexual violence and abuse. I haven't had any nominations for that role, so I suggest again we discuss that as a committee and agree who should be our representative outside this meeting today, and we can have a discussion if that's acceptable. Yeah. Okay. Item 17, information previously circulated. There's a list of items there. Anybody want to, therefore noting, any comments? Have I missed anything? No. Is any further comments? If not, I shall close the meeting. Oh, Chief Exec.
Yeah, Chair, just in terms of departure of the Director of Public Health, and for those who may be aware of the changing weather situation, I'll just say that considering you're the Scrutiny Committee for Public Health, that I've asked that we send something out to all members later. We are in tactical emergency planning about that across every directorate to just understand the implications about the seriousness of the heat that we are expecting. In Devon over the next few days, you'll note from national media, I know Patrick's involved, that there is an area of the south of England that now has a red alert. We need to keep close to understand the implications for Devon, or whether that should change in the next few days. But you know, we will update you, and I think it's just important to say that because you are the Scrutiny Committee in this area, and can't stress enough what a concern the situation, particularly for our elderly residents, in terms of and how we deliver services over the next few days. So we will get something to you later once Steve comes out of those meetings, so you can get that update. And also we will ensure that the kind of guidance that's available, because it's very different kind of guidance that's available nationally, that all members have that to circulate as widely as possible, because it's going to be a challenging few days, and we want to make sure that you can support your residents as best you can, because that's now saying that, you know, certain hours of the day people should not be out in direct sunlight. So I just want to stress the seriousness of the situation, that even for really healthy people, we are taking national advice, but we'll circulate that as best we can. Okay.
Thank you very much. That's appreciated. Thank you for that. So on that point, I shall close this meeting. Thank you.
Thank you, Chair.